Hello, this is the third in a series of talks regarding quality improvement for the Nebraska Quality Improvement Project. Today we're going to talk about the chronic care model. The objectives of this presentation are to describe the importance of the chronic care model to quality improvement in primary care settings, and I think you'll understand by the end of this presentation why I think this is so important. You're also going to learn to describe the internal components of the chronic care model, the external components, and we're going to explore a comprehensive application of the chronic care model to diabetes care in a primary care setting. In other words, I'm going to spend a fair amount of time talking about one particular example. The reason the chronic care model is so important, particularly to this project, is because not only is this project focused on chronic illness, particularly heart disease and diabetes, but really in the future primary care is going to be a lot about both the prevention and management of chronic illness. And the chronic care model is really the only comprehensive evidence-based model that is out there that really helps you to approach quality improvement and chronic illness care together. And it's an important part of the quality improvement process, and it results when used properly in better clinical outcomes and higher patient satisfaction. Another section of internal components are the decision support and the delivery system design. Decision support is very much provider focused, and these are things like practice guidelines such as the American Diabetes Guidelines or the National Heart, Lung, and Blood Institute Guidelines on heart disease. And I find that clinician education is very important in decision support. Again, the evidence shows that this improves the processes of care, but it doesn't always improve the clinical outcomes for the patient. Another one is delivery system design. We can talk, and we'll talk a little bit more in the future about planned and group visits, about case management and primary care teams with expanded roles. Again, it improves care, but there's less evidence that it improves clinical outcomes. But these are the things you do, like having hours on Saturday morning or late into the evening or early morning hours, whatever works best in your practice. For example, in my practice right now, patients seem to do better when we have early morning hours, and nobody comes in the afternoon, and so we've clustered most of our hours in the morning because that works better for our patients. So that's the delivery system design that we've done to try to improve our access to care. The two external components that I mentioned are community resources. I was just talking to my students the other day and to some clinicians about community resources and how much they knew about the resources in their community, who to call to get diabetes education or to get smoking cessation classes. Who can you send your patients to when they need help with a prescription? Unfortunately, there's been very little research regarding community resources, probably a large percentage of the reason being that it's kind of hard to do research in the area. When we work on it, rather than trying to build new resources, what I try to do in my practice is build bridges to pre-existing resources and help patients to access those resources. So, for example, giving them phone numbers, having them call for an appointment while they're sitting there in your clinic. Bringing the resources into your practice. For example, in my previous practice, we had the Nebraska AIDS Project came on every Tuesday night and did HIV screening for my patients. And so that was a community resource. I gave them a room, and my patients had access to that at no cost to them. And as I mentioned earlier, self-management support is really important. It's very complex. It's about patient education. We all talk about patient education, and patients need to be educated, but it's not sufficient. They need help with problem solving and goal setting, and as I mentioned before, we're going to spend a whole class on that the next session, and there is excellent evidence that this does, when done well, improve clinical outcomes, which is why I think it's so important in quality improvement to spend a lot of time on self-management support strategies. So we're going to spend the rest of the time using reviewing the chronic care model from the perspective of a particular scenario regarding type 2 diabetes. What do we know about type 2 diabetes? What we know is that a lot of the variation related to outcomes is not related to provider-specific behaviors. And this is probably too fancy a narrative for you all, and I apologize for this, but the idea is that if you have a patient with a hemoglobin A1C of 8 or a blood sugar of 400, or a patient with a hemoglobin A1C of 6 and a blood sugar of 150, that variation really isn't because the provider or the nurse or the front desk people really did much particular about it. What we know is that a lot of it has to do with socioeconomic factors, stress, powerlessness, lifestyle issues, and community and cultural issues. And that means that the provider in the clinic has to spend a lot of time pulling back from this one-on-one interaction with a patient and looking at how you're going to improve your clinical outcomes based on this idea that poor people have trouble with their diabetes, that people have lifestyle problems related to their diabetes, and that some communities and some cultures have more problems than others. So what I'm saying here is that we need a different intervention model. We can't use just standing in a room and writing prescriptions and saying to a patient, okay, now you have to count your carbohydrates and you have to stop drinking soda pop, which are all good things to do, and here's your metformin and here's your insulin. We have to do all of those things, but it's much more complex than that, and so we need another model, and that's where the chronic care model comes in. So, that new model. Let's start with decision support. Remember, that's one of the internal factors or components of a comprehensive plan. So, what do you do with decision support? One of the things we recently did in our practice was print off the Diabetes Association flow sheets on diabetes care and put them in every patient's chart who has type 2 diabetes, so that when the provider opens a chart, they can look down and say, okay, when was the last time an A1C was done? When was a foot check? What was their LDL? And so it's a whole list of things to help the provider remember what to do and what to check. Another thing that providers can do, and again, this is something we've done recently, is go to continuing professional education. You know, nowadays we need to start diabetics on insulin much earlier than we now know that we need to start them much earlier. It's not an easy thing for a provider that's used to doing just the oral medications, and so sending them continuing professional education. Another decision support tool is internet access to guidelines, so that you can say, okay, what is the newest thing on this, and you can go to guideline.gov or some sort of other thing. So these are things that you can do in your practice to help the providers and the nurses, all the staff, to stay up to date on how to practice in this new world and provide comprehensive care to your patients. The second component of the chronic care model that we'll talk about is delivery system design and things you can do differently. One of the things that surprised me, and look at your practice and think about your clinic and how you do your diabetes care. Do your patients with diabetes come in for a regular checkup diabetes visit, or do they get their diabetes checked when they're in because they have some other problem? Obviously, in the best of all worlds, you want a planned visit. In other words, a scheduled, it's time for my diabetes check every 3 months or every 6-month visit. And so that's a way you can design a system where that when the patient leaves, the front desk knows to schedule that appointment, not just to check them out, but to schedule another appointment in 3 months for their diabetes check. They can schedule an appointment 2 weeks before that, perhaps to have their lab work done and to have some of their routine checkups. So when the doctor, the physician assistant, or the NP sees the patient, all that information is already sitting in front of them. Another thing that you might want to look up on the internet and find out how people are doing is something called group visits, where patients actually come in and you do a visit in a group. I'm not going to spend a lot of time with that. It's a fairly complex intervention, but I will tell you I've done it in my practice, and the patients actually like it quite a bit. but it's much more comprehensive or complex than we have time to talk about now. But if anybody's interested in group visits, I'll be happy to work with you on it. What about the idea of a diabetes-specific clinic day or team? Again, my nurse practitioner, or one of the nurse practitioners at my clinic, has decided that she wants to have a diabetes day, and so the patients all come in on a particular day. And obviously this doesn't always work, but this is part of what she wants to do so that she knows that that day she's spending the whole time focusing on that. We also have a point-of-care A1C machine in our clinic, so not only can we get same-day glucose, but we can get a same-day real-time A1C so that the provider knows right away how that patient's been doing in the last 3 months. Another delivery system design that we use in our clinic that's invaluable is having nurse case managers. These are nurses who, because we have very vulnerable patients with lots of complex problems, these nurses do home visits, they help with pharmacy assistance, they facilitate getting our patients to specialists, all sorts of different things. Plus they reinforce all of our patient education and help us to understand what's going on with the patient in the real world. So these are all things that are very complex interventions that are part of delivery system design that can improve the outcomes for your practice and your patients with type 2 diabetes. And of course, this would apply to any other kind of health problem, chronic illness problem. As I mentioned earlier, the clinical information system is probably the one thing that you're most familiar with, because this is what the Nebraska project has been all about to a large degree, is the patient registry. So you've been entering data and getting data on a regular basis that tells you about how the practice is doing with regard to your patients with heart disease and with diabetes. And so that's what a clinical information system is about. As you well know, having lived through this for a period of time, it's fairly labor intensive. You need to either have an electronic health record that collects these data for you, or somebody who can enter these data. In my previous practice, I actually had somebody who entered the data on a regular basis. I had a graduate assistant, cheap labor, so if maybe a high school kid, somebody's son can come in and enter the data. But in the best of all worlds, you get an electronic health record that allows you to access these data from the record that you're using. But another example of a clinical information system is a pop-up reminder that comes up in the electronic records, so that when a patient comes in for a visit and the provider opens their electronic health record, it says, it's time for this patient's mammography. So those are examples of clinical information system interventions. This is a trend chart, and I suspect that you've been getting these because of the work you've been doing with the Nebraska project. But what you're looking at here is the percentage of patients, and you see it started out as 8% in August of 2005 and slowly worked up to our benchmark goal of 60% of patients with an A1C of less than 7. So this is just an artificial trend chart, but it's what we talked about in the last talk with this idea that you look at the percentage of patients, your goal, the benchmark. Remember we talked about in the last lecture setting a benchmark. Well, in this case, the benchmark is 60% of patients will have a hemoglobin A1C of less than 7. And this is a chart that shows how it's slowly moved toward that goal. And that's where the clinical information system is so important, to tell you how you're doing with the group of patients, not individuals, but with the aggregate. I probably should have started with the organizational support, but again, I'm just reinforcing what I've told you before, how important it is that the organization supports this quality improvement project. At University of Nebraska Medical Center, for example, they have actually dedicated staff whose job it is to do pharmacy assistance. And so there's, we refer patients to them. We used to when I was practicing there, and they would help with the paperwork. They would receive the prescriptions, and the patient would go just like they were going to the pharmacy, and they would see a pharmacist, and they would get their pharmacy assistance medications. And when it was time for these to be renewed, they would mail the stuff to me, and I would sign the prescriptions, and it was just continued. So that's organizational support. Another thing that University of Nebraska Medical Center did was charity care for the uninsured. So there was another organizational support, and they provided access to specialists for us. Everybody is different. You're in small practices. Organizational support in your practice means that the providers and the leadership give you a couple of hours a week to meet as a quality improvement group to look at the data and to plan things. And perhaps they give you a small budget to do some interventions that will help to improve the quality of the care. So the resources that the organization provides can be time, personnel, and or funding for practice improvement. So in my practice, I give the staff a couple of hours a week to have a meeting, and I give them a small amount of money to spend for practice improvement. Sometimes it's not that small, but I give them some money. Just recently, the nurse practitioner asked for access to UpToDate, which is the software that you can load on your computer to give you quick access to information. Again, going back to that idea of decision support tools. And so we looked at how much it would cost in a variety of ways to access it, and I approved it in one of the ways that we can do it, the least expensive, because it was very expensive. Community resources, you know better than most communities what your resources are because you're small communities. There may not be much. I lived like you in a community once that didn't have a mall, so we can talk about exercise resources such as, in fact, I live in a community now that I think of it, that doesn't have a mall nearby. But a mall walking program or the YWCA or YMCA or support group. Or, for example, in my community now, I know that I can send my patients to an organization called the Jesse Tree, and they'll help them to buy one prescription a year. I can send them to a mother's support group for moms with lots that are high risk for child abuse, to be perfectly honest, and there's a support group for those moms, and so I refer patients to them. So you need to know what your community resources are, build bridges with them, and send patients to them. And if you don't have a resource, maybe you need to think about being part of the community and advocating for it. A walking trail, whatever works in your community. Access, another thing that you could do is talk to the local school about access to the gymnasium and see if you can have a walking program in the evening when students aren't there. So those are just ways of building community resources, a very wide number of things. And finally, self-management support strategies. Again, diabetes education, because we're talking about type 2 diabetes, is important, but it's not enough. A patient can know all about how to take care of their diabetes. I know, and you know, how to eat healthy and how to exercise. We know lots of things, but we don't always make the right decisions on. So that's, as I mentioned earlier, is why we're going to spend a whole class on self-management support, because that's an important part of quality improvement and successful clinical outcomes. A big piece of it is goal setting regarding lifestyle changes, and you'd be amazed the difference that a little bit of work with goal setting will make. I mentioned that I had a group that had group visits over a period of 6 months a couple of years ago, and they started setting goals and just made amazing progress with these little goals, and they weren't goals that we would normally set. Here we are in this group, and this couple is talking about what they eat and starting to disclose their eating habits, and I discovered that they're both eating 4 fried eggs and 4 pieces of toast, whole wheat, with butter every morning for breakfast. And so we set a goal of going to 2 eggs and 2 pieces of toast in the morning. And, they lost weight and they did really well. And, of course, everybody would say they should have had a goal of oatmeal. But the truth is, you've got to set realistic goals. And that's what we'll talk about at the next time we have a session. And then resource utilization, are the patients using the resources that are available to them, such as the Y and such as American Lung Association for Smoking Cessation. And then decision-making skills, helping a patient. One of the things that we forget is how much we just know things like, can you take this pill and that pill together? My sister-in-law calls me sometimes, and she's a highly educated woman, and says, well, it says here that I can't take this pill and drink wine, and, I'm taking it, something like niacin for her heart, for cholesterol. And she wants to know if she can take niacin in the morning and have a glass of red wine at night. And so she needed just that little help with that decision making, because she had read the flyer on the medication and was concerned. And so it's not as easy as we think. And so these are all ways that we can provide self-management support for our patients. So in summary, talking about chronic care model, in healthcare today, we need a care delivery model that addresses complex factors that influence chronic illness. It's not just telling people what they're supposed to do and giving them their prescriptions. Even accessing their medications is sometimes a challenge, and I know you all know that perfectly well. We all live that and know it, but we haven't done much about it. We haven't really had a model. And so when you start planning your quality improvement interventions, the advantage of the chronic care model is it looks at all of these factors. It looks at the provider, it looks at the system, it looks at patient, and it looks at social factors. So it's a significant advantage to look at this in a much more comprehensive way using this model. Okay, we're talking now about your assignment for this week, or this session. And I want you to use the aim and the benchmarks and the strategies you identified in assignment number 2. And using that aim, which let's say is to lower the LDLs of your patients who have identified coronary artery disease, identify at least one intervention in each of the 6 areas of the chronic care model and send those to me. I don't want you to implement them in PDSA cycles. Just write one intervention that you can think of in each of those. So for example, in delivery system design, it might be to have the patient come in 2 weeks before their visit to have fasting lipids drawn, so that when the provider sees them at their visit, they have the lab data in their hands. And so that might be an intervention that you could think of in the area of delivery system design for the aim of lowering the LDLs. And then I want you to take one of those 6 interventions and implement them with at least 2 PDSA cycles. And I'm going to walk through in the next 4 slides examples and talk to you about PDSA cycles again so that you remember how to do this. This is just a reminder to send the information to me, and yet again reminding you about my email address. And be sure the report includes all the details of the PDSA cycle. And I know I said the next slide, but I meant the next slide after the next slide, to show you an example of PDSA cycles in the next slides. And I'm going to talk through them so that you are either terribly bored or you find this useful. It's up to you. So here's an example of a PDSA cycle, and the objective or the aim is that all children, I'm using peak flows, and this is the plan part, and I'm doing it using peak flows because I know that's not what you all are working on. You're working on diabetes and heart disease, and so I wanted to use something completely unrelated. So the objective or the aim would be that all children with a history of asthma will have a peak flow collected as part of their intake at each office visit. So that's your aim. All children with a history of asthma will have a peak flow collected as part of their intake at each office visit. And I'm here to tell you I've done this. And so I have lived experience with this, and it was very interesting. So in the PDSA, this is the plan part. What's the objective? Who is responsible? In the case of this particular one, we'll say it's medical assistant number 1 and medical assistant number 2. So it might be Joni and Mark. And what will Joni and Mark do? Well, when they check the patient in and they see into the room and they do the intake and they see if they have a history of asthma, they collect a peak flow. And we can go into details about that, but it should be 3, they would collect it 3 times, and we would make sure that they knew how to do it right and all of this. Now, when will they do that? They're going to do it all of next week. So today is Thursday. We're having a quality improvement meeting, and we set this up and say next week, starting on Monday, Joni and Mark are going to collect peak flows on every kid that comes in. Now, this probably is not going to be that many children. It might be 3 or 4 kids that Joni and Mark see. And what is the expected outcome? This is the planned part of a PDSA cycle, and the expected outcome is that each child with a history of asthma seen this week will have 3 peak flow measures recorded on their encounter form. So the D, the do part of it. Well, the medical assistants in this case, and this is okay, the reason I did it this way is so that you can see it's okay not to be successful. They weren't able to start the process because there weren't enough peak flow meters, plus they needed some sort of a form to record it on. So they ran into a bollocks, a little problem, and so they weren't able to start it, but they've got the idea. And so, of course, what they're going to do is order peak flow meters to make sure they've got enough, and, maybe call up the Advair rep or something and get a couple peak flow meters and make sure they have a form. And while they're at it, I hope they remember or the mouthpieces so that the next time they go to do it, they aren't without parts. So what's the study part? So what are you going to do based on what the do was? The medical assistant 1, that's Joni, is going to develop a little form, and Mark, medical assistant 2, is going to order supplies. And then they both met with the clinic nurse to review the process for doing peak flows and calculating the averages and how to document the results. So in other words, they remembered that not only did they need to get all the material together, but they all want to meet and make sure they're doing it right. So they're making sure the patient is standing, and that they know how to collect the data, and that they how to average it and how to document it. And so while they're at it, while they're waiting for the supplies to come in, here's what they're doing. And here's the ACT piece of the example. As soon as the materials are in, they will implement the plan to collect peak flows starting with step 2. And step 2, medical assistant number 1, which is Joni, will test the form with 2 patients as soon as the materials are in. So this is the write-up for 1 PDSA cycle. Now what's going to happen is Joni's going to do this form with 2 patients, and then that's going to be the second PDSA cycle. So it's really, it's simple, and yet it's not simple. And I know it seems complex, but after a while you get used to it, and it makes a lot of sense, and you'll understand why we're doing it that way. You have my manual on how to do this, and so you might want to go back. If there's several places where we have examples of PDSA cycles. So if this one isn't working for you in terms of writing it up, try looking at another resource, or for heaven's sakes, just send it to me and let me give you some feedback on it. But this is a good place to start, and I look forward to seeing your material and seeing how this works. Thank you very much, and have a nice day.